Okay, so I'm going to go ahead and get this last portion of the chapter done. And I apologize that it's taken me multiple videos or recordings to get this done. If you haven't watched the video yet from the calculations book, I had noted, said in there that having some issues with my Zoom account. So I'm having to record just per the screen, and it's not as user-friendly or what I'm used to. So bear with me on these. All right, so we're going to pick up. So what we were talking about last was the category of our traditional anti-epileptic drugs, and it shut down on me when I was trying to go to another web page to look up the pronunciation of the word. So the adverse reactions we're talking about, I'm on page 181, and again I'm picking back up with those traditional anti-epileptic drugs. So phenytonin is a pterogen which causes birth defects, so it should be avoided during pregnancy. And other adverse reactions of phenytonin include red blood cell anemia, reduced white blood cell counts, which is going to increase your risk of infection, because remember from microbiology that our white blood cells is what is part of our immune system that fights infection. Also, it reduces platelet counts, which is going to increase your risk of bleeding. So if you think about platelets is what causes our blood to clot. So if we don't have platelets and you get a cut or stick or anything, then it's not going to have those platelets to aggregate around that puncture site, and so you can bleed out. So some other not so common ones are heart rhythm problems, especially bradycardia. So brady means slow or low, so it's going to be a slow heart rate. Rashes can be caused, and it can become progressive and known as something as Stevens-Johnson. So anytime that they're on these drugs, also a lot of your mental health drugs have that serious side effect of Stevens-Johnson. And so what Stevens-Johnson does is it starts out as a rash. So if they've started on these new drugs, if they start any rash at all, they're to call their doctor immediately, because with Stevens-Johnson, as it progresses, the skin starts to slough off or starts to peel off and fall off, and it has a lot of other complications that's going to be part of it that requires immediate attention. So think about it. If your skin starts to blister and bubble and peel, bust and peel and slough off, do you think you're going to be at risk for infection? Do you think you're going to be at risk for dehydration? Are you going to be, you're not going to have that protective layer anymore of your skin. So again, that any significant onset of that rash should be notified the healthcare provider immediately. So our carbamazepine, also like our phenytonin, affects the bone marrow. Okay, so if it affects the bone marrow, this is where our red blood cells and such are made. So it's going to lead to different anemias. Okay, and if it's going to affect reduce our white blood cells, again, that's going to increase our risk of infection. If it's reducing our platelet counts, it's going to increase our risk of bleeding. Okay, heart rhythm problems may lead to tachycardia, and so tachycardia is going to be rapid heart rate. Also atrial fibrillation, which is an extremely high heart rate. That the atrium is fibrillating, so it's not getting a full, complete contraction, and that heart rate can get up to, 125, 150, 200, and severe hypertension. So phenobarbital and primidone can cause severe central nervous system depression. So especially when it's given parenterally. So remember, parenterally means it's giving within the vascular system, okay? If it's enteral, it means it's given through the GI system. Parenteral is going to be anything that's given like IM, sub-Q, IV, okay? It can cause respiratory depression, and so you should not be given to patients who have chronic um, airway obstruction pulmonary disease. So COPD, you do not want the patients to give to this because, and if they have any other severe respiratory impairments, we don't want to give them the phenobarbital because it will depress that that respiratory drive. Okay, so it has risks for physical and psychological dependencies, especially with long-term use. So it is classified as a Schedule 4 controlled substance. So you want to make sure that also if it's got physical and psychological dependency, okay, if that patient is physically and psychologically dependent, can we just stop that medicine? No, because the body is depending on that. It is and if it's no longer getting it, it can have severe withdrawal symptoms that can possibly lead to death. So many other possible side effects, again, such just as the other ones: bone marrow, depression, cognitive impairment, exfoliative dermatitis, liver impairment, bradycardia, and coma. So, in cases of acute overdose, the patient shows exaggerated CNS depression. So, if it's exaggerated, it means it's a lot worse than it normally would be. So, they would have slow and shadow respirations, they would have small pupils, they would have tachycardia, they would have absence of reflexes, they would go into shock or a coma and then eventually die from pulmonary cardiorespiratory failure. So what happens is that slow and shallow respiration is not getting enough oxygen to the body, to the brain, and what happens is then they go into respiratory failure. Respiratory failure then which causes cardiac failure. So our valproic acid has been known to cause amnesia and heart rhythm irregularities, especially tachycardia. So hearing loss and GI bleeding is also possible. So lifespan considerations. So serious liver toxicity can be seen in children. So do you think that we need to have a baseline levels? Yes. Okay. Do you think that they need to have um, um, regular blood work done? Yes. Okay. So the risk of liver toxicity decreases as the child ages. So let's see, 2 years old. Okay. Pregnancy. So phenytonin, carbamazepine, phenobarbital, primidone, and valproic acid are all teratogens, which means that they're going to cause birth defects. So if there's that risk of birth defects, the drugs are not to be used during pregnancy unless they're not able to control the seizures any other way. So drug interactions, so they're so the list of drugs that interact with these is very long. strong and very common drugs. So aspirin, Tylenol, contraceptives, PPIs, which is going to be your protein pump inhibitors such as Nexium and Prilosec. These are very common drugs that people take normally on a regular basis. So they're not going to be able to use these drugs if they're on this medication. Also, drugs that are used to manage psychiatric problems. Also, warfarin, which is your generic for Coumadin. They can cause severe complications. So it's up to the doctor and the patient to determine is the complications or the potential for risk for adverse reactions, does the risk outweigh the benefits, or does the benefits outweigh the risk? And they have to decide together what is going to be best for that patient. So newer anti-epileptic drugs, there are about a dozen or so that's considered newer. Some of the drugs have been around for years, and then they're also can be used to treat other conditions. And so let's see. However, it says that most must be used along with or added to a regimen that includes a traditional AED. So that's going to be an adjuvant therapy. So when they add an additional medication onto a treatment that they're already having. Okay, so it says only 4 drugs have been approved for use as single drug therapy. So single drug therapy is called monotherapy. So mono means one, and then of course therapy. So these can be used to treat the epilepsy, and what they'll do is they'll replace the traditional AEDs. So the prior part says that, okay, we have these new drugs, but they don't work unless you still taking them with the traditional ones. And so you're still having all those side effects of the traditional anti-epileptic drugs, and then you adding on the new ones. But if you use these 4, then that's a single drug therapy. So that means you don't have to take the traditional ones. You're not going to have all of those adverse reactions and side effects from the traditional treatment. So so the list of the drugs and the nursing implications are in this next set of tables. But what we're going to do is, as we always do, is we're going to go down. We're going to look at the drugs. We're going to break them down individually as a group. Not individual, but as a group. And then we'll come back and you can look at the table, how they combined them all. All right, so let's go to page. All right. Let's see. All right, so let's just look at just the drug name. So the epileptic drugs that are approved just for monotherapy. So that means they would only have to be on this one without any traditional anti-epileptic drugs. So we have the oxcarbazepine, the lamotrigine, lacosamide, and topiramate. So all of these, that's going to be your generic names, and then you have the brand name. So your Topamax is what you're going to see, the brand name that's used in the States. The Vimpat is again the only the only brand name for this one. The Lamictal, and then the Trileptal. So some of the newer anti-epileptic drugs that are approved for adjacent therapy. is your ezogazobin, your felbamate, your progabalin, your rufamide, your tiagabin, your vigabatrin. Boy, these names are horrible. So, the state board wants y'all to know the generics, and I know I've said this 100 times, but when I went to school 30 years ago, we were taught brand names because the way state board worked was they'd put brand name and generic. So some years back, the state board decided that everybody should practice and use generic names only. So it's a matter of, it's not that I don't know the names, it's just they're very hard to pronounce. And so I have to do a lot of practice at them. But the brand names are so much easier. And so a lot of nurses, especially your old school nurses, are going to still use the brand names because that's how we learned them. And so you really need to know both names, even though on state board they're only going to give you generic. When you get out there in the real world, you're going to have to know both because depending on who you're talking to, they may use a generic or a brand name. Now, most MARs, when you're passing out meds, they're going to have both names. They're going to have the brand name and they're going to have the generic name. And so if you knew one or the other, then you would know the drug. So it talks about, again, this memory jogger. You do want to know these 4 medications for anti-epileptic drugs that are monotherapy. Again, monotherapy means that they're just treating the epilepsy with just that one drug without having to add any traditional drugs to it. So let's talk about those monotherapy drugs. So we have our oxcarbazepine, oxcarbazepine. Okay, so this is going to be our AD that is derived from carbamazepine. Okay, and so carbamazepine is a traditional anti-epileptic drug. Okay, and it reduces the seizures by blocking those sodium channels. Okay, on the neuron membrane. So this requires greater stimulation for them to depolarize or to fire. So it rises the seizure threshold. And remember, we talked about what that means on yesterday. So I'm not going to go back into that again. So it says, although the structure is similar to the traditional carbamazepine, it has fewer of the central nervous system side effects. So it can be approved to control partial seizures. So the most common side effects of your oxcarbazepine, oxcarbazepine, I don't know, it's not coming out right. It's going to be your drowsiness, dizziness, headaches, and nausea. Okay, they may also have those visual side effects of double vision or blurred vision. So the most common adverse effects is going to be that amnesia and the low sodium level, so hyponatremia. And so we would want to monitor that sodium level, and you need to know, you should know already, and if you don't, you have to remember that that sodium level is going to be 135 to 145. So rare problems can be bone marrow suppression and confusion, just as with the traditional ones. They can have depression, suicidal ideations, and that although that it's less likely than the traditional ones to cause birth defects, it's still not recommended for pregnancy. So the drug interactions, the drug lowers your blood sodium level, and so if the patient is taking a sodium excreting diuretic, then that's going to decrease that sodium level even more. So it also interacts with many common drugs, such as your aspirin, your Tylenol, oral contraceptions, your PPIs, your psychiatric drugs, HIV drugs, and drugs for diabetes. So it seems like almost everything. So to prevent the severe complications, you want to avoid any prescription drugs unless, again, we want to know, does the benefit outweigh the risk? Now, who is the ones to decide that? The doctor and the patient is the ones to decide if the interactions, if the benefits are going to outweigh those interaction risk. So again, you're planning. So we want to make sure that we always get our initial assessment on the patient, the initial blood levels, such as the sodiums, the lab values. Again, you want to make sure that they're not lower than 135 before it starts. But again, you also want to make sure that you're educating the patient on the signs and symptoms of low sodium. So their headaches, their increased muscle weakness, decrease in tendon reflexes. If they're having any of that, they need to report that to the doctor immediately, because they probably need to have some lab work done to make sure that their sodium levels are within normal limits. So teaching points, again, we want to make sure they keep all their appointments for their lab testing. We want to make sure that they don't drive until they, if they're experiencing blurred vision or double vision. We also want to make sure that any increase in their muscle weaknesses, headaches, any of those things that are true signs of that low sodium, that they're notifying the doctor. And then also, if they're taking oral contraceptives, they need to have an additional form of protection, okay, because the drug does reduce the effectiveness of hormonal contraceptives. All right, so your lamotrigine is that, again, a newer one. The mechanism is unknown, but it's believed that it blocks the sodium channels on the neuron membranes. So again, it's for monotherapy, and it's used to treat partial seizures, tonic-clonic seizures, and seizures associated with Lennox syndrome. It's also approved for bipolar disorder. So remember, we talked about that some of these drugs have more than one usage. When this drug first came out, after it was out for a while, the bipolar was actually an off-label use. But now the research shows that it actually can be used for that. Now again, you have to know, if you see that your patient is on this drug, you need to know it. Are they on it for seizures, or are they on it for bipolar? Because that's going to make a difference. So the most common side effects are drowsiness, abdominal pain, visual disturbances, also ataxia, dry mouth, and dizziness. And if you've noticed, as we're going through all these meds, any of these central nervous system drugs, all of their side effects are very similar because they're affecting the central nervous system. So it says that also an unusual issue with lamotrigine is that its clearance rate is lower among black patients, which can lead to symptoms of overdose, even with usual recommended doses. So again, if this is the case, then the doctor's going to have to be doing the monitoring of the blood work, which they should be doing anyway. Also making sure that you are educating your patient on the signs and symptoms that they should be monitoring for, and if those symptoms begin, they need to notify the doctor immediately. So adverse reactions, again, those life-threatening rashes such as Stevens-Johnson, okay, or toxic epidural necrolysis. So that's where, again, that epidermal layer dies off. It gets necrotic and it starts lysis, which just means it starts falling off the body. Okay, so the patient can die from this. So we want to make sure that we are aware of that black box warning related to the rash. Okay. Also, the drug interferes with formation of folic acid. So, what did you learn back in nutrition? That folic acid is extremely important for us. So people who are women who are going to become pregnant, because the folic acid is needed within those first few weeks of development to make sure that they don't, that their spinal column closes all the way and that they're not born with either spinal bifida or they're born with a lack of part of the brain. So we want to make sure that we also don't give it to, that we understand that it can cause birth defects, so we don't want it to be given during pregnancy. And then just like your traditional ones, we want to monitor for the depression and the suicidal ideations, because that is possible. So again, just as your other anti-epileptic drugs that we've been talking about, your lamotrigine can also cause interactions with basic drugs such as aspirin, Tylenol, oral contraceptives, PPIs, cardiac drugs, psychiatric drugs, HIV drugs, tuberculosis drugs, diabetes drugs, pretty much everything. Okay, so you have to be very mindful of your patients who are on anti-epileptic drugs to see what all of they're on. Also educating them not to take things over the counter, that they have to make sure that they are outweighing the benefit and the risk with their doctors. Okay, so again, you want to refer back to that box 10.6 for those general nursing implementations. And then you also want to make sure that the patients are not skipping doses, that they understand that if that rash starts, to withhold the next dose and call the doctor immediately. Also assessing Black patients very carefully for side effects, and teaching them about the extended release drugs, if they're on them, not to chew them, to swallow them whole. Also, if they become, the mouth comes too dry, they can suck on candy, they can drink water, and then again, if they're having that blurred vision or double vision, we don't want them to drive. So, lacosamide is the modified amino acid with an unknown mechanism of action that appears to control seizures by acting at the sodium channel to stabilize neuron membrane and prevent the repeated excitation and firing. So pretty much what that is saying is that it's acting again on those sodium channels. So if you remember, or if you paid attention to any of all of these drugs, almost every one of them is working on that sodium channel. Okay, and so this one again is working on that sodium channel. It's stabilizing those neuron membranes. So remember, the seizures are caused from the excess excitability or firing of those nerve endings. Okay, so those neurons, if we stabilize them, then it's going to stop all that firing and it's going to stop the seizure activity. So again, it's a monotherapy and it's approved for partial seizures. And it can also be used as an adjunct treatment. So you can also, the doctor can add it on with some of those other AEDs to get better coverage for the patient. Alright, so again, some expected side effects. Again, because we're dealing with the central nervous system, headache, dizziness, blurred vision, double vision. Okay, also fatigue, nausea, ataxia. Okay. How much I got left on here? Alright, so I'm going to stop here, and I'm going to pick back up with lacosamide in the next video.